Hello there, this is Dr. Brian Buchanan. Today we'll talk about physics and knowledge for the EFAST exam. Learning the EFAST exam really happens in three separate steps. First of all, we have to talk about image acquisition. This involves some ultrasound physics, some knowledge, and of course some hands-on. Next, when it comes to interpretation, physics and knowledge is also essential, as generating those images and evaluating them requires accurate acquisition. Finally, providing accurate clinical applications require that you understand limitations and considerations. The goal of this tutorial is really just a simple physics knowledge to understand acquisition and interpretation. And I hope, above all, you practice and revisit this lecture frequently, as we'll cover some more difficult concepts, which may become more clear with future practice. Ultrasound really is frequencies above human hearing, greater than 20,000 hertz. It's generally between 2 to 18 megahertz, as you can see on this scale beneath. Ultrasound waves are generated from a piezoelectric crystal. If you apply electrical current to piezoelectric material, it goes through phases of expansion and contraction, generating sound waves. In turn, that ultrasound beam is transmitted into tissue and is reflected off interfaces with different densities, including tissue planes and blood and tissue borders. This reflects back to the ultrasound transducer and results in the opposite effect. That is, contraction and expansion of the crystal with generation of electrical current. When you look at object appearance on 2D imaging, it's really determined by two things. That's depth and brightness. First off, it's time for the echo to return to the probe. That is, with a longer time of transit, we see that increased depth versus a shorter time. The strength of the returning echo determines the level of brightness. Again, some more basic principles looking at wavelength and frequency of sound waves. In the first case, higher frequency means you have shorter wavelength and increased resolution. You've probably seen this with performing central lines and looking at superficial venous and arterial structures. It's got great resolution but poor penetration. In a lower frequency probe, we see longer wavelengths. This results in better penetration. This is more commonly illustrated in a curvilinear probe, that big blunt probe you see commonly strapped to the machine in the trauma bay. This again allows us to see deeper into internal structures and evaluate abdominal viscera. Again, a basic concept is that our 2D image is broken down into the near field, that's the more proximal portion of the image, and the far field. Now let's go over some basic interaction of sound waves with tissues. We're not going to go deep into this, but cover just enough so you understand some basic principles. When an ultrasound wave travels through a homogeneous medium, its path is a straight line. When the medium is not homogeneous, or there's different interfaces, we see this path can become altered. The relationship between waves and tissues can be described in terms of reflection, scattering, refraction, and attenuation, amongst others. We're going to focus on how these interactions affect the production of artifacts, which are commonly seen in performance of the EFAST exam. First of all, reflection. Ultrasound beam hits a tissue boundary interface. We know that a certain percentage of ultrasound is reflected back to the transducer. This is most commonly illustrated with a strong reflector with high attenuation, such as the outer cortex of bone. This results in a hyperechoic signal that's quite bright. As a consequence, no ultrasound can pass the bony cortex, and we see a shadowing artifact with an anechoic region extending downward from the highly attenuating structure. This shadowing prevents display of true anatomic structures. This is because there's a high percentage, nearly 100% is reflected. This we can see on the left with intervening ribs on a parasagittal plane of the thoracic cage. On the right, we see a more instructive acoustic shadow, where this is the gallbladder with a cholelithiasis. Again, with a strong attenuator and reflector, we know reflection is greatest at interfaces with biggest differences in impedance. As you can see, air here has an impedance much lower than other structures, and often results in significant reflection. This is most commonly demonstrated when you cannot pass the bowel gas to visualize abdominal structures. In this case, we see the gradient of echogenicity. On the top of the scale here, we see anechoic. That means that the ultrasound wave passes through the fluid without any internal echoes or attenuation. In this case, we see the patelorenal space in a small sliver of anechoic space, which represents fluid. On the other extreme, we see hyperechoic, that's bright. In this case, can be demonstrated with fat in the renal sinus, which is more echogenic, and the outer renal cortex of the kidney, which is more hypoechoic. Air is often the biggest enemy in ultrasound. That's why we use ultrasound gels like coupler. This helps to transmit the ultrasound beam with no attenuation into the patient's body. Let's go over some basic artifacts that you may encounter. We've already talked about acoustic shadowing, which again is a strong attenuator with significant reflection, causing a hyperechoic signal. You may also see this difference in the tissue-way interface in the lung portion of these EFAST tutorials. In this case, we can see the pleural line. And what happens is the ultrasound beam travels from the probe to the pleural line and gets reflected off in its entirety back to the probe because of this tissue-air interface. Instead of being absorbed by the probe, it's again reflected off the probe. We now have two parallel strong reflectors. The machine interprets this time to detection of the ultrasound wave as being double the time and generates an equidistant A line. This artifact is quite instructive in examination of the lungs, however, is often seen in many parts of the body when you have significant differences in acoustic impedance, commonly called a reverberation artifact. This is a mirror image artifact formed by a nearby dense reflector, which is the calcified diaphragm. This occurs when there's a highly reflective surface in the path of the primary beam. And essentially what we are seeing is a duplication artifact by this parallel reflector. I'm not going to go too far into this, but suffice to say that mirror image artifacts are commonly seen in the posterior thorax. It can also duplicate the texture of the liver above a diaphragm, giving a look of consolidation. Posterior acoustic enhancement. This occurs most often in fluid-filled structures such as the urinary bladder and the gallbladder. We see that the ultrasound beam travels through the fluid-filled structure with complete transmission. This may lead to an increased brightness and echogenicity and the loss of ability to identify structures distal to that structure. Many debates have been held about probe selection. The most common probes you'll see used in trauma bay are the curvilinear probe and the phased array probe. This depends on the machine you have access to and the probe you have more comfort with. You'll have a chance to use both probes during the workshop. The linear probe is most commonly used in vascular access, but can also be used for lung, importantly. Finally, please don't drop the transducer, as it can lead to a loss of that piezoelectric material and disruption of the probe, as we can see drop out here of this image. Probe handling is important to master. You can see here this is a pencil grip that is being applied here for precise application. If you can anchor your palm or wrist in the patient, that can really help to stabilize your hand. And you may require variation of grip depending on the scanning area. Our probe orientation is generally with the screen marker left. This should correspond to the probe marker, which is on the left. We can see here there's a small knob delineating the left marker. This marker depends on the vendor. This could be a light, this could be a line, but it's important to understand how this is used and applied on your particular machine. In traditional imaging, the screen marker is left. This corresponds to the probe marker being cephalad, or towards the head, on the left side of the screen. In cardiology-based imaging, we see the screen marker right, which in this case, the probe marker is, again, more cephalad. In our EFAST tutorials, we will keep the screen marker left to avoid any confusion with this particular orientation. However, do not be surprised if you have your colleagues in cardiology who ask you about the screen marker. Anatomical planes are also important to understand in performing ultrasound as you're acquiring a 2D image. So again, remember the sagittal plane, coronal plane, and transverse or axial plane. You've probably heard of different kinds of imaging, from 2D or B mode imaging, to M mode imaging, to Doppler and color Doppler imaging. We're going to really focus on 2D imaging during this EFAST tutorials, as M mode imaging and Doppler imaging are much less likely to be used during performance of the EFAST exam. 2D imaging is the default mode of most ultrasound machines. It's also called B mode or brightness mode, which determines echogenicity by observed structures, which depends on the intensity of reflected signals. This allows for real-time imaging of a 2D space. From an knowledge standpoint, you really must know your machine. So I would encourage you all to become familiar with the machines you have access to. That way you're not scrambling to understand which buttons you need to press to optimize your image. So knobs that are used with the highest frequency include depth, gain, we can see here right. This is time gain compensation, or gain at depth, near and far. This is a global gain. This is auto gain. And we'll discuss gain shortly. Know how to freeze your image, how to take a clip of an image, which is generally 3 to 6 seconds. You should also know how to type text on your screen, which may be important for recording and documentation. And finally, imaging types. Now again, these buttons are placed differently on different vendors, different machines. What is the difference between these two images? If you guessed gain, you'd be right. Gain is the amplification of the returning signal. If we turn the gain up, we actually turn up signal and noise. And we can see an image right here, the gain is so high that the signal of the internal cavity is becoming almost a bit more hyperechoic, whereas it should be anechoic. This is really noise. This gain is appropriately adjusted so internal structures that are fluid-filled are anechoic. It is very common for novice bedside sonographers to turn the gain up very high, and this leads to a loss of the signal. That time gain compensation button we talked about earlier is really just gain at depth, whether in the near field or far field. This is commonly seen as a series of sliders on the ultrasound machine. Again, here is the time gain compensation and auto gain. We covered physics of ultrasound, probe selection, probe orientation and movements, and different types of imaging. Finally, wrapping it up with understanding knobology. Thank you for listening to this tutorial on physics and knobology for the EFAST examination. Bye for now.